I was thinking recently, usually when we talk about our bodies, there is this underlying expectation of consistency. Like we just expect things to stay the same.
Right. You wake up and just assume you are essentially the same machine you were 10 years ago.
Yeah, exactly. Maybe just with, a few more miles on the odometer. But if
Mhm.
you actually stop and think about it, the evidence against that is literally everywhere.
Oh, it really is. It is completely undeniable once you pay attention.
Like, for everyone listening right now, do you ever wonder why you could eat an entire large pepperoni pizza as a teenager at midnight, sleep flawlessly, and then wake up ready to sprint a mile?
Oh, man. The golden years of metabolism.
I mean, it is true, but now, if you are an adult, a late night handful of potato chips gives you relentless heartburn and throws off your sleep architecture for the entire week.
It really does feel like a fundamental betrayal of the system, honestly.
Totally a betrayal. It is like the instruction manual for our own metabolism just gets rewritten overnight, and nobody bothered to send us the memo.
Right, because we expect the operational rules to stay the same.
Yeah.
We want this static set of rules for healthy eating that we can just memorize in our 20s and apply forever.
Yes. But the human desire for a static, universal diet is just not realistic.
Not at all. When you step into the actual science of human aging, that static instruction manual has to be thrown completely out the window.
Because we are looking at a nutritional landscape that is a constantly moving target.
Exactly. It is the absolute definition of a dynamic biological system. Nutrition is not just about the chemical composition of what is on your plate.
Right, it is way deeper than that.
It is deeply intertwined with the age of your cells, the current state of your endocrine system, your hormone levels, and crucially, your psychosocial environment.
Which perfectly brings us to the mission of our deep dive today. We have compiled a highly comprehensive stack of lecture slides and clinical notes on life cycle nutrition.
These were curated by Dr. Helena Nanditi.
Yes, exactly. Curated by Dr. Nenti. And using these sources, we're going to track the human body's relationship with food across the entire lifespan.
From beginning to end.
Right. We are starting in the chaotic, hormone-fueled construction zone of adolescence, and then moving through the high-stakes maintenance phase of adulthood.
And ultimately, navigating the really complex physiological adaptations of our golden years.
It is quite a journey, and the overarching theme that emerges from these sources is that the biological objective of the human body fundamentally shifts depending on your life stage.
It really does. We're going to explore the underlying mechanisms today, like the specific why and how behind our body's changing demands.
Because it is not just biology, is it?
No, it is a really complex interplay of biology and psychology that dictates our nutritional reality.
So let us begin at the period of the most dramatic physical change outside of infancy. We're talking about adolescence.
The big construction zone.
Yeah. And the sources define this as ages 10 to 24. Now, that age range immediately caught my attention.
Because it seems older than you would expect.
Right. Because the World Health Organization typically defines adolescence as ages 10 to 19. So 24 feels really late.
Well, the WHO definition is widely used, sure. But nutritionally speaking, ending at 19 simply does not align with the biological reality of what is happening.
So what is actually happening up to age 24?
The sources emphasize that the nutritional window of adolescence extends to 24, because that is how long it takes to complete the physical, cognitive, and social transition to full adulthood.
Wow. So the body is still building itself in your early 20s.
Exactly. The body is still actively mineralizing bone and, myelinating the frontal lobe of the brain well into those early 20s.
I think about this period kind of like a massive commercial building project. Like, if you are managing the construction of a skyscraper, you do not order your drywall and paint based on how many days the project has been running.
Right. The chronological age of the project does not matter.
Exactly. You order your materials based on the actual stage of construction. Like, have the steel beams been placed? Is the plumbing finished?
That is a highly accurate way to visualize it. The body works the exact same way. Chronological age tells you almost nothing about what a teenager actually needs to eat.
So how do doctors actually measure this if age is basically useless?
Well, in a clinical setting, pediatricians and dietitians rely on something called Tanner staging.
Tanner staging. Okay, how does that work?
It categorizes sexual maturation and physical development across 5 distinct stages, totally independent of a child's birth certificate.
Oh, so it just looks at the physical evidence.
Right. It tracks the onset of puberty by observing the development of primary and secondary sex characteristics.
So you could have two kids the exact same age with wildly different needs.
Precisely. A 13-year-old could be in Tanner stage 2, just beginning puberty with relatively low nutritional demands.
While another 13-year-old could be way further along.
Exactly. They could be in Tanner stage 4 in the absolute peak of their growth spurt,
Yeah.
requiring thousands of additional calories just to sustain that rapid cellular division.
That is wild. And this construction project goes in two wildly different directions depending on your sex.
Absolutely.
Yeah.
Driven by completely different hormonal cascades, the physical divergence is staggering.
Let us examine the female trajectory first, because the growth spurt typically initiates earlier for them, peaking around 11 to 12 and a half years of age.
Yes, and the weight gain during this window is substantial.
How much are we talking about?
On average, females gain about 21 pounds during this specific developmental window.
21 pounds is a lot in a short time.
It is, but the composition of that weight is the critical factor here. It is primarily a significant increase in essential body fat, which is mediated by rising estrogen levels.
And this is where things get tricky, because society often bombards young girls with messaging that any fat accumulation is negative.
Which leads to immense psychosocial friction.
Exactly. But looking at the biology, this fat deposition is non-negotiable for survival. It is absolutely essential for reproductive health.
It really is. The body uses adipose tissue, which is just fat cells, to produce a hormone called leptin.
Okay, leptin. What does leptin do in this context?
Well, when those fat stores reach a critical threshold, leptin signals the hypothalamus in the brain that the body finally has enough energy reserves to sustain a pregnancy.
It is like flipping a switch that says the fuel tank is full enough.
Right, and that trigger releases gonadotropin-releasing hormone, which eventually cascades down to initiate menstruation.
So if they do not gain that fat,
If that essential fat is not laid down, the brain literally perceives a famine state and simply halts reproductive development.
wow, so the biological imperative just overrides everything else. It has to happen.
Exactly. Now, on the male side, the construction timeline is delayed. Their growth spurt peaks later, typically around 13 to 14 years old.
And they pack on even more weight, right? The sources say averaging a 34-pound increase.
Yeah, 34 pounds. But the composition of that weight is completely different.
Because it is driven by the surge in testosterone instead of estrogen.
Yes. For males, the weight gain is characterized by a pronounced increase in lean body mass, specifically skeletal muscle and bone density.
So females are building the essential energetic reserves for future reproduction, while males are expanding their musculoskeletal framework.
That is a perfect summary. And to fuel this rapid, sex-specific construction, the body is pulling massive amounts of raw materials straight from the bloodstream.
The sources highlight two micronutrients that become absolutely critical here: calcium and iron. Let us start with calcium.
The calcium requirement during adolescence jumps to 1,300 milligrams a day.
That is a huge amount. Why is the demand so immense?
Because the ability of the intestines to absorb calcium and the bones to retain it is higher during this window than at any other point in the human lifespan.
So it is a now or never kind of situation.
Very much so. The osteoblasts, the cells responsible for building new bone matrix, they're working in absolute overdrive.
So this is the window to build that bone bank account.
Exactly. This is the singular critical window for achieving peak bone mass. The density of the bone you build by age 24 is essentially your primary defense against osteoporosis when you are 70.
Yet the data in the slides shows a massive failure rate here. A huge proportion of adolescents are completely missing that 1,300 milligram target.
It is a major public health concern. And this creates a severe vulnerability for one specific demographic highlighted in the research.
The female adolescent athlete, right?
Yes. This is a highly monitored group in sports nutrition because when you combine insufficient calcium intake with the immense physiological stress of competitive sports,
You get a perfect storm.
right? And often there's an energy deficit from not eating enough overall calories on top of it. This low energy availability actively suppresses estrogen production.
And since we know estrogen normally protects bone density, its absence means the bones become incredibly vulnerable.
Exactly. Because the body operates on a very strict hierarchy of needs. It prioritizes keeping blood calcium levels stable for immediate survival functions.
Functions like what? What is more important than bone?
Electrical signaling in the heart, for one, and basic muscle contraction. So if a young athlete is not consuming enough calcium, the body just deploys cells called osteoclasts.
To break down bone.
Yes, they break down the newly forming bone and steal the calcium right back into the bloodstream to keep the heart beating.
Oh, wow. So the skeletal system is basically treated as a highly liquid bank account.
That is exactly what it is.
Hmm.
The body makes heavy withdrawals to fund immediate metabolic needs, completely sacrificing long-term structural integrity.
That is terrifying, but it perfectly explains why female adolescent athletes with poor nutrition are at the highest risk for stress fractures.
It is a direct mechanical consequence. Now, iron demands also see a dramatic spike during this time, again for completely different reasons based on sex.
Right. Females require 15 milligrams a day, primarily to replace the iron lost through menstruation. But males require 11 milligrams a day.
Yes, and the male requirement is driven by the sheer volume of new tissue being created.
Because they're adding all that muscle and blood volume.
Precisely. They are rapidly expanding their total blood volume, which requires iron to produce hemoglobin, the protein that carries oxygen in red blood cells.
And the muscle tissue needs it too, right?
Yeah, they are laying down significant amounts of muscle, and muscle tissue requires iron to produce myoglobin, which stores oxygen locally within the muscle fibers.
The sources offer a really fascinating mechanical tip regarding iron absorption here, because there are two types of iron, right? Heme and non-heme.
Right. Heme iron, which is found in animal products like beef and poultry, is highly bioavailable. The body absorbs it very easily.
But if a teenager is relying on non-heme iron, the type found in like spinach, lentils, or fortified cereals, the body actually struggles to absorb it efficiently.
Yes, because non-heme iron is in a ferric state. It is chemically locked up.
So how do you unlock it?
You have to pair it with vitamin C, like drinking a glass of orange juice or eating some strawberries with your iron-fortified cereal.
Because the acid changes the chemistry.
Exactly. The ascorbic acid chemically reduces the iron into a ferrous state. It unlocks it so the intestines can actually pull it across the cell wall.
That is amazing. It is such a simple biochemical intervention that drastically alters nutrient uptake.
It really is.
Okay, so we have established that teenagers need an incredibly precise, high-volume matrix of calcium, iron, proteins, and healthy fats just to physically construct a resilient adult body.
They need a lot of raw materials.
Yet, practically speaking, adolescent diets are notoriously terrible. So why is the drive for fast food so powerful during this specific window, despite these needs?
To understand that, we have to look at a psychological concept detailed in the sources known as social reorientation.
Social reorientation, is that basically the shift from caring about parents to caring about peers?
That is exactly what it is. Throughout childhood, the primary social environment is dictated entirely by the parents. The family unit controls food procurement, meal timing, and dietary norms.
But then adolescence hits and the brain changes.
Right. It marks an evolutionary drive toward independence. The adolescent brain begins to heavily prioritize peer acceptance and social bonding over parental compliance.
So food choices suddenly become a primary vehicle for social signaling.
Exactly. They want to eat where their friends are eating, because sharing a meal at a fast food restaurant is a way to assert autonomy and solidify their place in the social hierarchy.
So it is rarely about the actual food itself. It is about the shared experience outside the home.
Spot on. A scoping review referenced in the slides analyzed these exact interpersonal determinants. It confirmed that the eating habits of a teenager's immediate friend group directly correlate with their own intake of fast food.
And sugar-sweetened beverages, I imagine.
Oh, heavily, yes.
But, you know, the peer group is not just the kids sitting with them in the cafeteria anymore. The sources bring up the digital environment, and the statistics on social media marketing are just alarming.
They really are. What was the specific stat from the 2025 study?
Yeah, so a 2025 study analyzing social media platforms found that nearly 90% of all food and beverage promotions by influencers were for products categorized as high in fat, sugar, and salt.
The HFSS category: energy drinks, ultra-processed snacks, fast food partnerships.
90%. That is almost everything they see. And the danger here lies in the psychological mechanism of influencer marketing, right?
Absolutely. When a teenager sees a traditional television commercial, their prefrontal cortex can often identify it as an advertisement and apply a degree of skepticism.
Like they know a corporation is trying to sell them a soda.
Right. But an influencer leverages a parasocial relationship. It feels like a recommendation from a trusted friend, completely bypassing that critical filter.
So the teenager's brain just processes it as peer behavior rather than corporate marketing. That is so sneaky.
It is incredibly persuasive. The integration of sponsored content into seemingly organic lifestyle posts makes it almost impossible to resist.
And the slides argue this demonstrates a critical vulnerability, highlighting the urgent need for updated digital marketing regulations to protect this demographic.
Without a doubt.
So, if you are a parent listening to this right now, this paints a really daunting picture. You are combating biological rebellion, deeply ingrained peer pressure, and a highly sophisticated digital marketing apparatus pushing ultra-processed food.
It is a massive uphill battle.
How does a family navigate this without turning the kitchen into a daily battleground?
Well, the clinical framework recommended in the sources is Ellen Satter's Division of Responsibility, often abbreviated as SDOR.
SDOR. I love this concept.
It is a highly effective strategy for establishing healthy boundaries while still respecting the teenager's biological and psychological drive for autonomy.
The brilliance of the SDR model is how clearly it defines the jobs of feeding. The parents act as the gatekeepers of the environment.
Right. They maintain total control over the what, when, and where.
So they decide what groceries are stocked in the pantry, they dictate the nutritional composition of the dinner being served, and they establish the structure of meal times and locations.
Exactly. They create the scaffolding. And crucially, the teenager is given absolute control over the whether and how much.
So let us play this out. If the parent provides a balanced dinner of roasted chicken, quinoa, and broccoli, and the teenager sits down and says, "I am only eating the chicken, I hate quinoa."
The parent does not intervene.
There is no forced feeding, no bargaining, no, you cannot leave the table until your plate is clean.
None of that. Zero. The parent has fulfilled their responsibility by providing the balanced meal. If the teen chooses to eat selectively, or even chooses not to eat at all, that is their prerogative.
By removing the pressure, you just eliminate the power struggle entirely.
Yes. And more importantly, this framework forces the teenager to tune into their own internal physiological cues of hunger and satiety.
Rather than overriding those signals just to comply with the parent or to rebel against them.
Exactly. It builds intuitive eating skills.
It sounds so counterintuitive to relinquish that control, but the data supporting the structure of family meals is compelling. The slides note a really remarkable statistic here.
Oh, about the risk reduction.
Yeah. Teenagers who consistently participate in family meals, defined as eating together just 5 times a week, experience a 35% reduction in the risk of developing disordered eating behaviors.
A 35% risk reduction is profound for a behavioral intervention, just sitting down together.
Because the family meal provides a consistent anchor point, right?
It does. It offers a sense of security, it facilitates open communication, and it allows parents to subtly model a healthy, relaxed relationship with a variety of foods.
And they can do all that without ever having to deliver a lecture.
Which is key because lecturing teenagers is pointless.
Which perfectly transitions into how we actually communicate with adolescents about health. Because, like you said, lecturing them about chronic disease is famously ineffective.
It just goes in one ear and out the other.
I remember adults telling me to avoid soda because it would cause diabetes when I was 60, and my brain simply could not process 60 years old as a real concept.
That is actually a known neurological limitation during this stage.
Really? It is not just them being stubborn.
No, the myelination of the prefrontal cortex, which is the area of the brain responsible for long-term planning and understanding future consequences, is still completely incomplete.
So adolescents are just inherently present-oriented.
Very much so. The clinical strategy, then, is to frame nutrition entirely around their immediate short-term interests.
You have to translate the biology into their current value system.
Exactly, which usually revolves around physical appearance, social standing, and athletic performance.
So you do not talk about osteoporosis when they are 70.
No, you talk about how sufficient calcium and protein will directly improve their vertical leap for the basketball team this season.
Or you link hydration to immediate improvements in skin clarity and energy levels during the school day.
Right. You have to connect the dietary habit to a goal they actively care about right now, today.
It is about shifting the narrative from restriction and fear, like avoiding future illness, to empowerment and optimization, building the capabilities they desire today.
It is a much more effective framing.
But this focus on physical appearance and performance, while it is effective for motivation, it carries a really dark shadow side.
It certainly does.
When we combine the immense physical changes of puberty, the intense desire for peer acceptance, and that digital environment where 90% of content pushes a specific aesthetic or diet,
Yeah.
It creates severe psychological friction,
It is a recipe for disaster.
which means we are moving from the construction zone into a phase where the eating behavior continuum breaks down entirely. Let us delve into the sources, extensive material on disordered eating and eating disorders.
This is such an important section. And the clinical framing here is vital. The sources emphasize a paradigm shift away from viewing eating behaviors as a simple binary of healthy versus sick.
So it is not just you have it or you do not.
Right. Eating behaviors actually exist on a very fluid, sliding continuum.
Okay, let us break down that continuum. On one end of the spectrum, we have normal or flexible eating, right?
Yes, this
It-
is the physiological ideal. Food choices are driven primarily by internal hunger and satiety cues, balanced with natural preferences.
So a person can eat socially without anxiety. They do not moralize food as purely good or evil, and they can adapt if their preferred meal is not available.
Exactly, it is flexible.
Mm.
But as you slide toward the center of the continuum, you enter the zone of disordered eating.
And this is highly prevalent in modern society, right?
Incredibly prevalent. This is where food choices become increasingly rigid and are strongly influenced by the desire to alter body weight or shape.
So we are talking about behaviors like chronic calorie tracking, ignoring hunger signals just to adhere to a diet rule, feeling intense guilt after eating certain foods.
Or using exercise specifically as a punishment for consuming calories.
And while that middle zone is common, it is a precarious place to live. Because at the far end of the spectrum, we reach the clinical category of eating disorders.
Right. This is where the rigid rules, the intense fear of weight gain, and the profound distress surrounding food begin to actively dismantle a person's life.
So where is the actual line between just being a health nut or trying a trendy diet and having an actual clinical disorder?
It relies on two specific metrics: distress and impairment.
Distress and impairment.
Yes. If the adherence to dietary rules is causing persistent psychological distress, like severe anxiety, depression, or obsession, or if it is impairing daily functioning.
Like causing the person to isolate from friends, perform poorly at work or school, or suffer physical health consequences.
Exactly. If distress and impairment are present, it requires professional intervention, regardless of whether it meets strict criteria right away. The presence of distress and impairment is the diagnostic line.
And the primary diagnostic tool for this is the DSM-5-TR, the manual used by psychiatric professionals.
Correct. And the sources highlight several vital updates in the latest text revision that have fundamentally changed how these disorders are recognized.
Let us start with anorexia nervosa, because there was a monumental shift in the DSM-5-TR regarding that, right?
Huge. It was a complete removal of the amenorrhea criterion for anorexia nervosa.
Now, for a long time, to receive a formal diagnosis of anorexia, a female patient had to demonstrate amenorrhea, meaning the cessation of her menstrual cycle for at least 3 consecutive months.
Yes, the old logic was that it proved a severe state of malnourishment.
But that logic was severely flawed, wasn't it?
It was terribly flawed because it created massive exclusionary blind spots in diagnosis.
First of all, it instantly excluded all male patients experiencing the exact same severe restriction and body image distortion.
Right. And it excluded premenarchal girls who had not even started their periods yet.
And what about women on birth control?
Exactly. It excluded women taking exogenous hormones, like oral contraceptives, which induce a withdrawal bleed regardless of their nutritional status.
So they were sick, but the manual said they weren't.
Right. So by removing the amenorrhea requirement, the diagnostic criteria finally became equitable. It allows these previously ignored populations to finally access specialized, insurance-covered treatment.
That is a massive life-saving change. The manual also adjusted the frequency thresholds for other disorders to capture them earlier in their progression, didn't it?
Yes. For bulimia nervosa, which is characterized by episodes of binge eating followed by inappropriate compensatory behaviors.
Like self-induced vomiting, misuse of laxatives, or excessive exercise.
Right. The threshold for those behaviors was reduced.
Yeah.
The behavior now only needs to occur at least once a week for 3 months to qualify for a diagnosis.
Whereas previous iterations required higher frequencies before you could get help.
Exactly. And the same adjustment was applied to binge eating disorder, or BED.
Which the sources defined as recurrent episodes of consuming large quantities of food rapidly, accompanied by a profound sense of losing control.
The person often eats until uncomfortably full and experiences intense guilt or disgust afterward.
But the key differentiator from bulimia is the absence of those compensatory purging behaviors, right?
Exactly. There is no purge. And like bulimia, the diagnostic frequency for BED is now set at just once a week for 3 months.
Establishing these criteria is obviously the first step, but understanding the underlying etiology, the actual why, is where the science has evolved dramatically.
Oh, the old misconceptions are finally dying out.
Right, because there is a persistent societal misconception that eating disorders are purely driven by vanity or a toxic media environment or just a lack of willpower.
The epidemiological and genetic data presented in the slides dismantle that notion entirely. It is not just willpower.
The genetic component is absolutely staggering. Researchers use twin studies and genome-wide association studies to measure heritability, right?
Yes, and the sources indicate the heritability of bulimia nervosa is estimated at approximately 0.60.
Wait, meaning 60% of the variance in the risk of developing bulimia is dictated entirely by genetics.
That is profound genetic load, 60%. And for anorexia nervosa, the statistics are even starker.
Really? How stark?
A female's risk of developing anorexia increases 11-fold if she has a first-degree female relative with the disorder.
11-fold. So you are literally fighting your own genetic architecture.
Yes, the environment like social media pressures, a traumatic event, or even just an innocent diet that just acts as the catalyst.
The genetics load the gun and the environment pulls the trigger.
That is the exact clinical analogy we use. And the sources also map out the fascinating neurobiological overlaps between eating disorders and other conditions.
Right, like anorexia shares a strong genetic correlation with obsessive-compulsive disorder and autism spectrum disorder.
The overlap with autism spectrum disorder is particularly illuminating. Well, in clinical practice, we see shared cognitive profiles. Many individuals with anorexia exhibit high levels of cognitive rigidity.
Meaning they get stuck on certain rules.
Right, a strong preference for strict routines, an extreme focus on detail. And when you combine this with the sensory processing differences often seen in ASD, such as an intense aversion to specific food textures or smells, it can manifest outwardly as severe dietary restriction.
Which we then categorize as anorexia. That makes so much sense. And on the binge eating side of the spectrum, disorders like bulimia and BED show strong genetic and neurobiological links to ADHD, correct?
Yes, and this connection centers primarily on executive function and dopamine regulation.
Because individuals with ADHD often experience deficits in impulse control.
And they have atypical dopamine signaling in the brain's reward centers. So binge eating can function as a subconscious mechanism to seek that dopamine surge and regulate an understimulated nervous system.
It is self-medication through food.
Exactly. And viewing these behaviors through a neurodevelopmental lens completely changes the therapeutic approach. It removes the shame.
Speaking of complex interactions, the slides outline a very specific, high-risk comorbidity involving type 1 diabetes.
This is a really challenging clinical scenario.
It is a unique situation where the necessary medical treatment itself creates the psychological vulnerability.
Because individuals with type 1 diabetes are forced to maintain a hypervigilant focus on their nutrition just to stay alive.
They have to meticulously track carbohydrates, constantly monitor blood glucose levels, and calculate precise insulin dosages multiple times a day.
Right. That intensive, numbers-driven focus on food and bodily control can so easily spiral into a disordered obsession.
And the most dangerous manifestation of this is colloquially referred to as diabulimia, right?
Yes. This occurs when a patient intentionally restricts or omits their life-saving insulin doses for the explicit purpose of inducing weight loss.
Because without insulin, the body cannot utilize glucose for energy.
Exactly. So the body just begins rapidly breaking down fat and muscle tissue instead, leading to severe malnourishment and incredibly rapid organ damage.
The physical toll of all these disorders is systemic and devastating. We see severe bradycardia, which is a dangerously slow heart rate, right?
Yes, along with massive bone mineral density loss and massive electrolyte imbalances.
However, the sources highlight a critical point regarding early detection. The first medical professional to actually spot the physical signs of an eating disorder is frequently not a psychologist or a primary care physician.
No, it is often the dentist.
The dentist. Oral health professionals are on the front lines of detection, particularly for patients engaging in self-induced vomiting.
The dental manifestations are undeniable if you know what to look for.
The primary indicator they look for is a condition called peristalsis.
Right, because when a person vomits repeatedly, the highly acidic contents of the stomach are forced into the oral cavity.
And this gastric acid physically dissolves the dental enamel.
It is a profound chemical erosion. Dentists look for this specifically on the palatal surfaces, The backsides of the upper anterior teeth, as those surfaces take the brunt of the acid wash.
The slides mention the teeth begin to look remarkably smooth, almost glassy, and the biting edges can become notched or transparent.
It is very distinct.
Mhm.
And alongside the enamel erosion, they observe bilateral parotid gland enlargement.
Meaning the salivary glands near the jaw swell up.
Yes, they swell significantly due to the chronic irritation and trauma of forced vomiting.
And dentists are also trained to look for Russell's sign, right?
Yes, Russell's sign presents as calluses, abrasions, or scarring on the knuckles of the back of the hand.
Which is caused by the skin repeatedly scraping against the incisors when the fingers are used to trigger the gag reflex.
Exactly. When a dentist observes this triad of symptoms, the peromolysis, swollen glands, and hand abrasions, it initiates a crucial, often life-saving referral process to specialized psychiatric and medical care.
And once a patient is in a specialized medical setting, particularly for severe anorexia nervosa, the protocol for nutritional rehabilitation becomes the primary focus.
Getting them medically stable.
Right. And the sources highlight a fascinating revolution in this area, demonstrating how clinical medicine constantly reevaluates its own dogma based on new data.
It is one of the most exciting recent shifts in eating disorder treatment.
Because for decades, the universally accepted medical protocol for refeeding a severely malnourished patient was governed by the phrase, start low and go slow.
Yes, patients were admitted to the hospital and given incredibly small amounts of calories.
Sometimes as low as 800 to 1,200 calories a day, and that number was increased at an agonizingly slow pace over several weeks.
The caution was entirely driven by the fear of triggering refeeding syndrome.
Which is a potentially fatal metabolic complication, right?
Highly fatal. Because when a body has been starved for a prolonged period, its cellular machinery adapts. When you suddenly introduce a large bolus of carbohydrates.
The pancreas responds with a massive spike in insulin.
Exactly. And insulin does not just move glucose into the cells. It drives electrolytes into the cells as well.
That is the mechanical danger. The insulin surge causes a rapid, massive intracellular shift of crucial electrolytes, specifically pulling them out of the bloodstream.
Phosphate, potassium, and magnesium. Phosphate, in particular, is required to create ATP, which is the basic energy currency of every single cell.
So if blood phosphate levels plummet,
Cellular energy production just halts, leading to widespread neurological dysfunction, respiratory failure, and fatal cardiac arrhythmias.
refeeding syndrome is terrifyingly fast. So to prevent it, doctors kept the calorie intake artificially low.
But the sources introduced the UCSF Strong trial, which fundamentally challenged this super conservative approach.
Because the strong trial hypothesized that keeping patients in a state of prolonged, medically sanctioned semi-starvation in the hospital is actually doing more harm than good.
It was prolonging their agony. So they tested a protocol that initiated refeeding with significantly higher calorie meal plans right from day one.
While aggressively supplementing electrolytes prophylactically and monitoring blood work constantly.
Right. And the data completely flipped the paradigm. The higher calorie approach was proven to be not only safe, but vastly superior.
Patients achieved medical stability and restored organ function significantly faster,
On average, it reduced the required hospital stay by 3 to 4 days.
which translates to an average cost savings of $20,000 per admission.
It is massive.
Yeah.
And it allows patients to transition out of the acute hospital setting and into intensive outpatient psychiatric care much sooner. The global standard of care is shifting rapidly because of this exact trial.
But fixing the physical malnourishment is only the first step. The psychiatric recovery is historically incredibly difficult.
It is the hardest part.
Which brings us to the future horizons of treatment highlighted in the slides, specifically the exploration of novel pharmacotherapies targeting the brain's neurochemistry.
Because right now, we currently have 0 FDA-approved medications specifically designated for the treatment of anorexia nervosa.
0. That is wild. The sources detail 2 cutting-edge clinical trials attempting to bridge that gap, the Spania trial and the Kettle trial. Let us look at Spania first.
The Spania trial is investigating the use of psilocybin, the active compound in psychedelic mushrooms, in a highly controlled, therapeutic setting.
The mechanism of action here is fascinating. We talked about how anorexia is characterized by extreme cognitive rigidity.
The patient's brain is locked into these inflexible, obsessive loops regarding food and body image.
And psilocybin acts primarily on the 5-HT2A serotonin receptors in the brain.
Right. Neuroimaging suggests that this interaction temporarily disrupts the default mode network.
Which is the brain system responsible for our rigid sense of self and our entrenched behavioral habits.
Exactly. So by essentially rebooting this network, the therapy aims to create a window of neuroplasticity, allowing the patient to finally break free from those deeply ingrained, disordered rules about eating.
It is like shaking an etch-a-sketch to clear the rigid lines.
That is a great analogy.
Now, while Spania focuses on cognitive rigidity, the KETTLE trial is exploring the use of ketamine to address a different massive hurdle in recovery: acute distress.
Because the physical process of refeeding in a hospital setting causes profound anxiety and depression for the patient. It is agonizing.
And ketamine, acting as an NMDA receptor antagonist, has shown remarkable efficacy in providing rapid-acting relief for treatment-resistant depression.
So the trial is assessing if administering ketamine during the acute refeeding phase can alleviate that overwhelming distress, making the physical recovery process psychologically tolerable.
It is all about making the hardest part bearable. But the rewiring of the system during recovery goes even deeper than the brain, doesn't it?
Oh, it goes all the way down. It extends down to the gastrointestinal tract.
The precision nutrition research on the gut microbiome during starvation is some of the most groundbreaking material in the slides.
We have to look at how the bacteria in the gut adapt to an environment with zero input.
Right. In a healthy, well-nourished gut, the complex carbohydrates and fibers we eat are fermented by bacteria, which produce short-chain fatty acids.
The most beneficial of these being butyrate. Butyrate is the primary and preferred fuel source for the cells lining your colon.
It keeps the intestinal wall healthy and prevents inflammation.
But during prolonged starvation, that bacterial ecosystem is forced into a radical survival adaptation. The microbiome fundamentally shifts its composition.
The populations of butyrate-producing bacteria just plummet.
Yes, and the system shifts to producing massive amounts of a different short-chain fatty acid called acetate.
Why the shift to acetate? What does that do?
Because acetate is a highly lipogenic, quick fuel. It is absorbed into the bloodstream with incredible efficiency and transported directly to the liver.
Where it is rapidly converted into adipose tissue.
Yes.
Fat.
Yes, the starving gut literally reprograms itself to become a hyper-efficient fat storage machine.
From an evolutionary biology standpoint, it is a brilliant mechanism. If a hunter-gatherer experiences a famine, their gut adapts to ensure that the absolute maximum amount of energy is extracted and stored from whatever scarce food they eventually find.
It is survival of the fittest at a microbial level.
However, in the clinical context of treating an eating disorder, this brilliant evolutionary adaptation backfires catastrophically.
It is the worst possible scenario.
Because when you begin refeeding a patient, their gut is functionally primed to convert everything rapidly into fat, which is the exact physiological response the patient is most terrified of.
Exactly. Furthermore, because the gut is devoid of butyrate, the colon cells themselves are starving.
This leads to severe gastrointestinal atrophy and dysfunction.
Patients experience intense nausea, severe bloating, and delayed gastric emptying.
So the food just sits in their stomach.
Right. The physical act of eating becomes intensely painful and uncomfortable, which powerfully reinforces the psychological desire to restrict food.
Therefore, modern nutritional rehabilitation is not just about calculating total calories.
No, it is an active effort to rehabilitate the microbiome itself. Specialized dietitians must design protocols using specific types of fermentable fibers to slowly steer the bacterial populations back toward butyrate production.
Healing the gut lining and restoring normal metabolic processing.
Exactly. It is highly precise work.
The sheer biological resilience we see during those early life stages is incredible. But this brings us to a major transition point in our deep dive. The intense construction of adolescence concludes, and we move out of that high-risk window for eating disorders.
The body is finally fully built.
We now enter the longest phase of the human lifespan, adulthood.
This is the maintenance phase. The biological objective shifts entirely here.
Because the rapid growth has ceased, right?
Right. The new goal is preserving the integrity of the machine and preventing the onset of chronic diseases of lifestyle, or CDLs.
Like cardiovascular disease, type 2 diabetes, and various cancers. And the overarching debate in this phase always comes down to environment versus genetics. Are we bound by the genetic code we inherited, or can our lifestyle and dietary environment override that programming?
The historical data provided by Dr. NPT makes an undeniable case for the power of the environment here.
The slides detail two massive natural epidemiological experiments, starting with the World War II rationing studies.
Right. During the conflict, several European nations, notably the UK and Norway, were subjected to severe government-enforced food rationing.
The population basically lost access to high-fat animal products, butter, and refined sugars.
They were forced into a diet heavily reliant on complex carbohydrates, root vegetables like potatoes, and whatever limited lean proteins were available.
It was an involuntary, population-wide restriction of saturated fats and calories.
And the epidemiological outcome of this enforced dietary shift was astonishing. Medical records from the era show a steep, dramatic decline in the incidence and mortality rates of coronary heart disease and type 2 diabetes.
We understand the mechanism now, right? The drastic reduction in dietary saturated fat lowered circulating LDL cholesterol levels in the population.
Preventing the buildup of plaques in the arterial endothelium. But the most telling piece of evidence came after the war ended.
When the food came back.
Yes. As soon as the supply chains recovered and the affluent, high-fat, high-sugar Western diet returned to those countries, the rates of cardiovascular disease and diabetes skyrocketed right back to their pre-war trajectories.
So the genetic makeup of the population did not change at all. The dietary environment was the sole variable driving the disease pathology.
Absolutely. And the sources reinforced this with the Japanese migrant studies conducted in Hawaii and California.
This is a classic study. Researchers observed individuals of Japanese descent living in Japan first, right?
Right. Their traditional dietary pattern, which included high amounts of salted, smoked, and pickled foods, resulted in a very specific national disease profile.
Extremely high rates of stomach cancer, but very low rates of heart disease and colon cancer.
Exactly. However, when these individuals migrated to the United States, they assimilated. They adopted the standard American diet.
High in red meat, highly processed carbohydrates and saturated fats, while dropping their fiber intake and physical activity levels.
And within a single generation, their disease profile completely inverted.
Their stomach cancer rates plummeted because they were no longer consuming the heavily preserved foods that irritate the gastric lining.
But they rapidly developed the exact disease pattern of their new environment.
Skyrocketing rates of colon cancer, breast cancer, and cardiovascular disease.
The Western environment completely overwrote their historical genetic predispositions.
It perfectly demonstrates that genetics provide the blueprint and perhaps the susceptibility, but the lifestyle environment ultimately pulls the trigger.
And the clinical application here, as noted in the sources, is how we frame this for adult patients. We must move away from the absolute term prevention.
Because if a patient has a strong family history of type 2 diabetes, eating a perfect diet of leafy greens and lean proteins cannot guarantee they will never develop the condition.
Exactly. It is far more accurate and frankly motivating to frame adult nutrition around risk reduction and delaying onset.
So if a patient's genetics predispose them to develop type 2 diabetes at age 45, but their rigorous lifestyle habits delay the onset of insulin resistance until age 65.
They have successfully bought themselves 20 years of elevated quality of life, completely free from the vascular complications of the disease.
In clinical terms, that delay is a massive triumph.
It is a huge win.
Now, navigating this maintenance phase requires understanding that the biological rules differ wildly between the sexes. Let us examine women's health first.
This is crucial. Historically, women's health is often casually dismissed as just a hormonal roller coaster.
Right, but looking at the actual cellular data in the sources, the shifting levels of estrogen and progesterone dictate a highly specific, protective biological framework across 3 distinct stages.
We begin with the reproductive years, spanning from menarche to menopause. As we established earlier, the regular loss of blood demands a sustained, high-level intake of dietary iron to prevent chronic anemia.
But if that woman enters the 2nd stage pregnancy, the physiological demands multiply exponentially.
The maternal body must construct an entirely new circulatory system, the placenta, the amniotic fluid, and the fetus itself.
This necessitates a minimum weight gain of roughly 11 kilograms just to support the fundamental biological structures.
And the micronutrient demands during this window are critical public health priorities. Folate, or vitamin B9, must surge early in the first trimester.
Because it is required for the rapid cellular division that closes the neural tube of the fetus. A deficiency leads to catastrophic defects like spina bifida.
Right. Iodine demands increase sharply to ensure proper development of the fetal brain and nervous system.
And iron demands are so high that iron deficiency anemia during pregnancy remains a leading cause of low birth weight and severe maternal complications globally.
But the most profound shift occurs when a woman reaches the third stage, menopause.
The cessation of ovarian function results in a dramatic, permanent drop in estrogen levels.
And the slides make it clear that estrogen acts as an invisible systemic shield for the female body. When that shield drops, the nutritional risk profile alters overnight.
Two major systemic changes occur. The first impacts the skeletal system. We discussed the osteoclasts earlier, the cells that break down bone.
Right. Well, estrogen actively suppresses osteoclast activity, acting as a brake on bone breakdown. When estrogen vanishes, that brake is released.
Bone resorption suddenly outpaces bone formation, leading to a rapid loss of bone mineral density and significantly elevating the risk of osteoporosis.
And the second major change involves the cardiovascular system. People often assume men simply have worse hearts, but the truth is estrogen protects women's vascular health.
Estrogen promotes the production of nitric oxide in the endothelial cells lining the blood vessels, keeping them relaxed, dilated, and flexible.
But it also dictates fat storage. Premenopausally, women predominantly display a gynoid fat distribution, storing adipose tissue in the hips and thighs.
And this subcutaneous fat is metabolically quite benign, right?
It is. Postmenopausally, however, the loss of estrogen causes the body to shift its storage pattern. It begins depositing fat using the android distribution.
Visceral adiposity, belly fat.
Yes, fat stored deep within the abdominal cavity, wrapping around the internal organs like the liver and pancreas.
And visceral fat is not benign storage. It is highly metabolically active tissue.
It constantly secretes inflammatory cytokines into the bloodstream, which directly promote insulin resistance, elevate blood pressure, and disrupt lipid profiles.
So following menopause, a woman's cardiovascular risk profile accelerates rapidly, eventually matching that of a man.
Exactly, which brings us to the male side of the adult continuum.
Male physiology in adulthood is primarily governed by testosterone, which sustains a higher proportion of lean skeletal muscle mass compared to women.
Because muscle tissue is metabolically expensive to maintain, men possess a naturally higher basal metabolic rate.
They burn more total energy at rest, which translates to higher absolute dietary requirements for overall calories and protein just to maintain baseline function.
However, the biological disadvantage for men is that they default to that dangerous android visceral fat distribution right from the beginning of adulthood.
So the accumulation of belly fat in their 20s and 30s is what drives their historically earlier onset of cardiovascular events and metabolic syndrome.
The biology sets the stage, yes, but the sources emphasize a critical psychosocial variable that exacerbates male health risks: the influence of masculine norms.
This psychological aspect is fascinating. Traditional cultural scripts surrounding masculinity frequently frame proactive, health-seeking behaviors as inherently unmanly.
Statistically, men are less likely to schedule preventative medical checkups. Furthermore, cultural messaging often encodes an intense focus on nutrition, vegetable consumption, or dietary restraint as a feminine domain.
The stereotype that real men eat meat has profound epidemiological consequences.
It really does. When we analyze dietary patterns, adult men, on average, consume significantly higher quantities of red and processed meats, higher levels of saturated fat, and higher amounts of alcohol.
Conversely, their intake of dietary fiber from fruits, vegetables, and legumes is substantially lower than that of women.
And that specific dietary combination, high red meat, low fiber, high alcohol, is the exact established pathway to the two leading causes of premature male mortality:
Cardiovascular disease and colorectal cancer. It is a biological vulnerability amplified by a cultural expectation.
Exactly. The sources do highlight one specific area of targeted male nutrition, though: mitigating the risk of prostate cancer and benign prostatic hyperplasia as men age.
And the data strongly supports dietary patterns abundant in cruciferous vegetables like broccoli and cabbage, alongside a high intake of lycopene.
Lycopene is a potent antioxidant that accumulates directly in the prostate tissue, neutralizing free radicals that can damage DNA.
And the best biological source is cooked tomatoes, right?
Yes. The heating process breaks down the plant cell walls, making the lycopene highly bioavailable. So incorporating tomato paste or marinara sauce is a tangible, specific intervention for male health.
Now, whether you are managing the vascular changes of menopause or the prostate risks of male aging, there is a multi-billion-dollar industry waiting to sell you a shortcut,
Hmm.
the supplementation trap.
Oh, this is a massive issue. The modern adult often treats supplements like a metabolic cheat code.
A person might eat a highly processed fast food meal, but because they swallow a multivitamin in the morning, they assume they have balanced the equation.
The sources take a highly critical, evidence-based stance against this practice. Dr. Nkati's curriculum poses a fundamental clinical question regarding supplements. For whom, under what specific circumstances, and supported by what evidence?
Because the medical consensus is that supplementation is absolutely vital and sometimes life-saving for specific populations experiencing documented inadequacies or intense physiological demands.
As we discussed, folate for a pregnant woman to close the neural tube, or vitamin B12 for a strict vegan who consumes zero animal products.
Because B12 is entirely absent from the plant kingdom.
Right. In those targeted scenarios, supplementation is medical therapy. However, for the general, healthy adult population hoping to ingest a pill to prevent chronic disease,
Indiscriminate supplementation is largely futile and sometimes harmful.
the flaw lies in ignoring the mechanics of whole food synergy. People assume that if the vitamin C in an apple is beneficial, an isolated pill of pure ascorbic acid must be just as effective.
But that ignores the structural reality of the plant. When you consume a piece of broccoli, you are not ingesting isolated chemicals. You are digesting a highly complex matrix of insoluble fiber, water, vitamins, minerals, and thousands of phytochemicals.
And that complex structural matrix dictates how the nutrients interact in your gut, how slowly they are absorbed into the bloodstream, and how effectively the cells can utilize them.
A synthetic pill completely lacks this synergistic environment. The body often struggles to process high doses of isolated compounds.
Furthermore, treating a pill as an insurance policy often provides a false sense of security, causing individuals to neglect the difficult behavioral work of improving their actual diet.
And the biological risks of oversupplementation are real. If you take massive doses of water-soluble vitamins like vitamin C or the B complex, your kidneys simply filter the excess out.
You are essentially manufacturing very expensive urine.
Right. But the danger lies in fat-soluble vitamins, vitamins A, D, E, and K. Because they dissolve in fat, the body cannot easily excrete them.
If you oversupplement, these compounds accumulate in the liver and adipose tissue, eventually reaching toxic concentrations that can cause severe hepatic damage or neurological issues.
The overriding clinical mandate for adult maintenance remains firm. Derive your nutrients from whole foods first.
Always whole foods first.
As we progress through adulthood, despite our best maintenance efforts, the cellular machinery inevitably begins to degrade. We transition into our final life stage. Nutrition and aging, often referred to as the golden years.
The biological objective shifts once again here. We move away from the active prevention of disease and instead focus on managing existing conditions and optimizing physical function.
The central concept driving geriatric nutrition is the compression of morbidity.
The demographic reality makes this concept critical. By the year 2050, projections indicate that 20% of the global population will be over the age of 65.
Advancements in public health, sanitation, and pharmaceutical medicine have drastically increased our average life expectancy. We have successfully added decades to the average lifespan.
But importantly, our maximum lifespan has not altered.
The absolute biological ceiling for human life remains fixed around 110 to 120 years.
We are surviving longer. But the goal of modern gerontology is not simply to drag out the dying process by adding years of chronic illness, frailty, and institutionalization to the end of life.
The objective of compression of morbidity is to utilize lifestyle and nutrition to squeeze the period of physical decline and illness into the shortest possible window, right at the very end of the lifespan.
We want to maximize the active health span, ensuring an individual remains functional, independent, and vibrant until the final stages.
To achieve that compression, you have to aggressively fight the biology of aging. The most significant biological threat outlined in the sources for older adults is sarcopenia.
Sarcopenia is defined as the progressive, age-related loss of skeletal muscle mass, strength, and function.
People often assume muscle loss only happens in their 80s, but the data shows it initiates much earlier.
The decline actually begins around age 40, and without aggressive intervention, a person can lose 2 to 3% of their total muscle mass every single decade.
It is a relentless compounding loss. Sarcopenia is the primary driver of functional decline in the elderly.
A reduction in lean mass leads to a plummeting metabolic rate, decreased physical strength, severe balance issues, an exponential increase in the risk of catastrophic falls, and ultimately the loss of independent living.
This creates a fascinating mathematical paradox when planning a diet for an older adult. Because they are generally less active and possess less metabolically active muscle tissue, their overall energy requirements decrease.
They literally need fewer total calories to maintain their body weight.
So logically, should they not just eat less of everything across the board?
That assumption is a major driver of malnutrition in the elderly. While their caloric budget shrinks, their actual nutrient requirements, the essential vitamins, minerals, and specifically protein, either remain exactly the same or actually increase.
They have a smaller caloric budget, but they have to pack a higher density of raw materials into it.
It demands an incredibly nutrient-dense dietary pattern. It becomes mathematically challenging to meet micronutrient needs if an older adult is consuming fewer than 1,600 calories a day without meticulous meal planning.
And regarding protein, the standard adult recommendation of zero point 0.8 grams per kilogram of body weight is entirely insufficient to combat sarcopenia.
Why do they need more protein if they have less muscle?
Because aging muscle tissue develops anabolic resistance. The cellular signaling pathways that trigger muscle protein synthesis, specifically the mTOR pathway, become blunted and less sensitive.
To overcome this resistance and stimulate the tissue to rebuild, the older body requires a much stronger signal, which means a higher concentration of amino acids, particularly leucine, in the bloodstream.
Geriatric experts now recommend older adults consume 1.0 to 1.3 grams of protein per kilogram of body weight, spread evenly across meals, just to maintain their existing lean mass.
But practically achieving that protein intake becomes mechanically arduous because, as the slides outline, the body's physiological systems start systematically betraying the individual.
The senses and the gastrointestinal tract begin to fail in subtle, compounding ways.
The physical act of eating becomes fraught with obstacles. It often begins with dysphagia, a clinical difficulty in swallowing safely due to weakening esophageal muscles.
This is frequently accompanied by xerostomia, a significant decrease in saliva production.
A chronically dry mouth makes chewing dense foods, like a piece of steak or a dry cracker, physically uncomfortable and sometimes dangerous.
Then you factor in the sensory decline. The olfactory bulb in the brain begins to atrophy, leading to a profound loss of the sense of smell, which directly blunts the sense of taste.
If food tastes like cardboard, the fundamental joy of eating vanishes. It transforms from a pleasure into a tedious chore, leading directly to a decreased appetite.
Furthermore, their neurological thirst mechanism degrades.
The osmoreceptors in the hypothalamus, which normally detect the concentration of the blood and trigger the sensation of thirst, lose their sensitivity.
An older adult can be clinically dangerously dehydrated, yet registers zero sensation of thirst. They have to be trained to drink water on a schedule rather than relying on biological cues.
But the most mechanically complex and paradoxical change highlighted in the sources occurs in the stomach, a condition called atrophic gastritis.
As the gastric lining ages, approximately 30% of older adults experience a severe decrease in the production of hydrochloric acid.
The parietal cells in the stomach simply stop pumping out enough acid. This creates a massive problem for the absorption of vitamin B12.
When you consume B12 in a natural whole food form, like in a piece of beef or an egg, the vitamin is tightly bound to the animal protein.
The stomach requires a highly acidic environment to physically denature the protein and cleave the B12 molecule away from it, allowing it to bind to intrinsic factor and be absorbed further down in the intestines.
If the stomach acid is weak, the meat passes through, but the B12 remains locked inside the protein matrix and is excreted entirely unabsorbed.
This leads to a stealthy chronic B12 deficiency, which is devastating because it causes irreversible neurological damage, cognitive decline, and pernicious anemia.
But this creates a fascinating paradox that violates the whole food synergy rule we established for younger adults.
Because the older stomach cannot chemically unlock the natural B12 bound in meat, this is one specific scenario where a synthetic vitamin is actually vastly superior.
The synthetic B12 utilized in fortified cereals, nutritional yeast, or a basic daily supplement is not bound to a protein matrix. It is in a free, unbound state.
Therefore, it completely bypasses the need for stomach acid. It is readily available for immediate absorption.
For this reason, clinical guidelines strongly recommend that older adults secure their B12 primarily from synthetic supplements or fortified foods, rather than relying on animal products.
It perfectly illustrates how the biological rules rewrite themselves. But even if we understand the biology, The psychosocial barriers to adequate nutrition in older age are immense.
The slides outline a screening tool used by clinicians called the Determine Checklist.
Determine is an acronym designed to rapidly identify nutritional risk factors in the elderly population. It evaluates disease, eating poorly, tooth loss or mouth pain, economic hardship, reduced social contact, multiple medicines, involuntary weight loss, needs assistance in self-care, and elder years above age 80.
Two of those factors interact with devastating synergy, reduced social contact, and multiple medicines.
Eating is, at its core, a communal and social behavior. When an older adult loses a spouse, or when mobility issues confine them to their home, they're suddenly eating every meal in isolation.
The psychological motivation to plan, prep, and cook a complex, nutrient-dense meal for a single person plummets.
This isolation frequently breeds depression, which acts as a direct, powerful appetite suppressant.
And that suppressed appetite is compounded by multiple medicines, clinically termed polypharmacy. Older adults are routinely managing an array of chronic conditions, often taking half a dozen or more prescription medications daily.
These pharmaceuticals frequently possess side effects that destroy nutritional intake. They can alter the chemical perception of taste, induce chronic nausea, cause the severe dry mouth we mentioned earlier, or fundamentally interfere with the intestinal absorption of vital nutrients.
It creates a brutal, vicious cycle. They take the medication to manage a disease and stay alive, but the medication destroys their desire and ability to eat, which accelerates their frailty and makes them more vulnerable to the disease.
This clinical reality brings us to the final paradigm-shifting statistic presented in the slides regarding body weight in older age.
Throughout adulthood, from our 20s through our 60s, the medical and cultural focus is entirely on staying thin, keeping our body mass index low to prevent metabolic disease. But as we enter our golden years, the entire script flips.
The epidemiological data reveals a complete reversal of risk. In advanced age, being underweight is statistically far more dangerous and highly predictive of all-cause mortality than being overweight.
The sources indicate that for older adults, a BMI ranging from 19 all the way up to 27 is the functional protective sweet spot.
To put that in perspective, an upper BMI of 27 is clinically categorized as overweight for a 25-year-old.
But for an 80-year-old, that modest layer of extra adipose tissue serves as a vital metabolic reserve.
If an elderly person contracts severe pneumonia, suffers a hip fracture from a fall, or requires major surgery, their body will undergo immense metabolic stress and hypermetabolism to heal.
If they are incredibly thin and possess no fat reserves, the body will immediately cannibalize their remaining skeletal muscle for energy.
This rapid muscle loss plunges them directly into severe frailty and loss of independence. That extra bit of weight acts as a crucial, life-saving buffer against the metabolic shock of acute illness.
The clinical takeaway is that we need to aggressively stop putting 75-year-olds on restrictive diets to lose 10 pounds.
The focus must entirely shift away from weight loss. In fact, unintentional weight loss is treated as a blaring clinical siren. If an older adult unintentionally loses 10% of their total body weight within a 6-month period, it is a primary diagnostic red flag for a devastating syndrome known as failure to thrive.
Failure to thrive. It is a haunting clinical term.
It describes a profound, often irreversible cascade of physical and cognitive decline. It's characterized by severe weight loss, complete loss of appetite, depression, and social withdrawal.
The ultimate objective of geriatric nutrition is to disrupt that cascade before it begins by prioritizing the preservation of muscle mass, maintaining functional independence, and frankly, prioritizing the psychological joy and dignity associated with eating a meal.
That perfectly summarizes the vast biological journey we have tracked today. We started with the intense, calcium-hungry cellular division of the teenage years, navigated the rigid diagnostic criteria of eating disorders, managed the hormonal shifts and vascular risks of adult maintenance, and finally adapted to the protein-critical battle against frailty in our final decades.
The organism is in a constant state of flux, demanding that our nutritional approach evolve right alongside it.
It is a process of lifelong adaptation. You cannot apply the biological rules of a 20-year-old to an 80-year-old system.
We have covered an immense amount of physiological ground today, unpacking the complex mechanisms behind these shifting needs. But before we wrap up, I want to pivot back to the psychological element. What is the key takeaway for the listener as they process all this biological data?
I urge you to reflect on that concept of social reorientation we discussed during the segment on adolescence. We established that this is the developmental window where peer influence, marketing, and your social environment fundamentally shape your food preferences and emotional coping mechanisms.
Right.
We have spent this entire session detailing how your physiological needs change as you age. But I want you to consider how your psychological relationship with food has changed, or perhaps has not changed.
That is a fascinating angle.
Think about the specific foods you reach for when you seek comfort, the meals you crave after a highly stressful day, or the deeply ingrained dietary rules you subconsciously follow. How many of those behaviors were hardwired into your neural pathways during that vulnerable adolescent period?
That is deep.
I invite you to examine your own habits tonight and ask yourself a difficult question. When you sit down to eat, are you accurately feeding the biological reality of the body you inhabit today, or are you still blindly feeding a psychosocial habit that was formed decades ago?
That is a profound perspective. Are you eating for the metabolic machine you are now, or the teenager you used to be? It is definitely something to chew on as you evaluate your own habits. Thanks for joining us on this deep dive.